I'm David Kandzari, the chief of the Piedmont Heart Institute and director of interventional cardiology for Piedmont Healthcare in Atlanta, Georgia, and the chief scientific officer for Piedmont Healthcare in Atlanta, Georgia. As a background for renal denervation altogether, hypertension still remains the global leading cause of death and disability. It affects more than 1 out of 3 adults. And despite treatment and awareness for selected patient populations, still more than half of patients with hypertension do not meet societal or guideline recommended treatment goals. And the treatment of hypertension is important because not only do small changes in blood pressure affect clinically relevant outcomes in terms of reducing stroke, death, and myocardial infarction, but again, it remains of significant public health impact worldwide. Treatment with renal denervation therapy in sham-controlled randomized clinical trials has demonstrated statistically significant and clinically relevant reductions in blood pressure, both in the presence and absence of antihypertensive medications. And even now, through 3 years of follow-up, we've demonstrated durability or sustained, if not amplified, reductions in blood pressure for patients who have been treated with this specific therapy without an escalation in their medication burden. But to explore the safety and effectiveness of renal denervation therapy in a context that might be considered more typical of clinical practice, that is integrating a device-based therapy like renal denervation therapy combined with pharmacologic strategies for the treatment of blood pressure and lifestyle interventions, we embarked on a sham-controlled international randomized clinical trial for patients with still uncontrolled hypertension, despite prescription of common classes of antihypertensive medications. The SPYRAL HTN-ON MED study was an international multi-center trial in which patients with persistent uncontrolled hypertension, despite prescription of 1 to 3 common classes of antihypertensive medications, were then randomized in a sham-controlled, assessor-blinded 2-to-1 fashion to treatment with renal denervation therapy versus sham control. The study's primary endpoint examined the difference in 24-hour ambulatory systolic blood pressure at 6-month follow-up, but it was very attentive as well to changes in systolic and diastolic office blood pressure, the win ratio, which is a hierarchical analysis considered of the opportunity for renal denervation therapy to reduce blood pressure or reduce medication burden, and very importantly, to the safety of renal denervation as well. These are patients who, in the study population, on average, had an office blood pressure, despite on average treatment with 2 medications, had a blood pressure of 163 over 101 over the 24-hour setting, approximately 150 over 96. And these are patients who are quite common in clinical practice, an average age of approximately 55 years, approximately 20% of the patients of Black ethnicity, where such reporting was permissible. And again, patients who are commonly encountered in clinical practice, but with persistent uncontrolled hypertension. The study was also performed according to a Bayesian analysis, meaning that based on a prior pilot study in an on-meds fashion in 80 randomized, sham-controlled randomized patients, these patients or the data from these patients could be borrowed in addition to a prospective cohort of 257 patients for a total population of 337 patients who were included in the study. So prior to 6 months, very importantly, prior to 6 months, which was the timing of the primary endpoint, we observed, despite similarity in the number of medicines and the medication burden at baseline between the 2 treatment groups, we observed statistically significant differences emerge at 3 months and were even exaggerated at 6 months, with a higher prescription of medications and medication burden in the sham control group. But importantly, this was confirmed by drug testing, drug adherence testing, urine and blood testing with the patient's awareness as well. And so in that context, at 6-month follow-up, the study did not meet its primary Bayesian endpoint with a reduction of 6.5 millimeters mercury over 24 hours for the ambulatory systolic blood pressure for renal denervation therapy, but unexpectedly a decline as well in the sham control group of 4.5 millimeters mercury. Diastolic measures over 24 hours also did not statistically vary. But on the other hand, through 6 months follow-up, treatment with renal denervation therapy was associated with a statistically significant difference, a greater reduction and a lower blood pressure with renal denervation therapy, a difference of about 10 versus 5 millimeters mercury at 6-month follow-up for the systolic blood pressure, and similarly, diastolic blood pressure was significantly reduced, favoring renal denervation therapy. What we observed in the study as well is that when we compared the patterns of ambulatory blood pressure between patients enrolled in the pre-COVID period compared with the during COVID period, recall that this trial continued its enrollment during the period early of 2020, in which there was a brief pause in trial enrollment, that for the patients enrolled during the COVID period, the ambulatory blood pressure patterns, both at daytime and nighttime, were statistically different, were significantly different compared with the pre-COVID population, implying that there may be differences in the patient's behavior or lifestyle patterns aside from the medication changes, which were quite significant. And to that latter point, with regard to the medication changes, in the expansion cohort, that is that continuance of the 250 sham-controlled randomized patients, there was a tenfold difference in the change in medications, in the net change in medications that would favor blood pressure lowering in the sham control group compared with the renal denervation group. More specifically, 22% of the patients in the sham control group experienced an increase in either drug number and or dose, compared with only 2% of patients in the renal denervation group. So quite significant changes that would influence blood pressure measures as well. Very importantly, too, we observed that the procedure itself was very safe. Consistent with many previous clinical trials, treatment with renal denervation therapy was associated with an exceptionally low risk of adverse events. And even through 6 months imaging, there was no disturbance or occurrence of restenosis, for example, of the renal arteries by imaging with ultrasound, CT angiography, or MRA. And finally, although there was not a significant difference compared with sham control per se for the 24-hour ambulatory blood pressure, the absolute reduction achieved with renal denervation in this study was 6.5 millimeters mercury for the 24-hour ambulatory blood pressure, which is not only clinically meaningful, but it's quite consistent with previous studies. Moreover, the absolute reduction of a 10 millimeter drop in systolic blood pressure was again quite consistent with 3 prior sham controlled trials using this specific therapy compared with a sham control group, all of which achieved their primary endpoint. So altogether, these findings continue to endorse the safety and effectiveness of renal denervation therapy with radiofrequency energy. Altogether, we now have 9 sham-controlled randomized clinical trials that have held renal denervation therapy to a very high scientific rigor, a very high scientific standard. And amidst these trials specific to radiofrequency renal denervation therapy using this technique, there's a remarkable consistency both in the presence and absence of antihypertensive therapies for this particular modality of renal denervation therapy to achieve a successful result in lowering blood pressure, and now even through 3 years of follow-up. So in this context, and given the consistency of safety observed with this therapy, the next steps are for regulatory submission, and for example, here in the United States, for hopeful FDA approval of this therapy so that we can extend it into routine clinical practice. Moreover, we're continuing to study renal denervation therapy only to further inform clinical practice. A large 1,000-patient study termed the AFFIRM trial is an international endeavor to further examine renal denervation therapy safety and effectiveness in a broader, less selected patient population who might have coexisting illnesses or conditions that would have excluded them from the more rigorous clinical trials. And finally, in parallel, over the past 2 years, there have been 12 documents that have come forward from societies and consensus statements from expert panel reviews with regard to renal denervation therapy and considerations for how this therapy may be incorporated into clinical practice, with an important emphasis on shared decision-making and also an important emphasis on patient preference, as more and more studies are coming forward suggesting that a high prevalence of individuals with uncontrolled hypertension may favor a therapy such as renal denervation therapy as an alternative to escalating their medication burden.